here. Welcome back to my channel. Today I'm going to be starting a antimicrobial stewardship series where my goal is to teach you how to assess a patient's antibiotic therapy and to teach you some simple stewardship principles that you can incorporate into your practice. My motivation for creating this series is because I want to empower all of you pharmacists to have the knowledge and skills to assess patients' antibiotic therapy. And I say this because as an antimicrobial stewardship pharmacist at a hospital, I find that pharmacists are often not comfortable or familiar with assessing patients' antibiotics. And this results in hesitancy in suggesting changes to them. I can relate to these pharmacists' struggle because I was like that too before I got further training in antimicrobial stewardship during my PharmD rotation. I think a part of it is because pharmacy school does not give us the tools and knowledge that we need in order to properly assess a patient's antimicrobial or infection therapy, despite this being a crucial skill to have. The Centers for Disease Control and Prevention, aka the CDC, has deemed antimicrobial resistance as a global threat. The CDC states that more than 23,000 deaths and more than 2 million illnesses a year are attributed to antimicrobial resistance. I am also seeing more patients coming into the hospital with multi-drug resistant pathogens that cannot be treated with the drugs that are available in Canada. This has resulted in poor outcomes, even deaths related to these infections, because it takes time for us to bring drugs in from other countries like the States when we don't have them readily available for use. And in most of these cases, we can see that they have received multiple courses of antibiotics in the past that likely contributed to the bacteria developing resistance to these antimicrobial therapies. With less funding going towards the development of new antibiotic therapy, we can expect this number to continue to rise. Therefore, by creating this series, I hope to share my knowledge with you so that we can all play a part in battling antimicrobial resistance and improve patient outcomes together. In this first video, I will take you through my systematic thought process when conducting my stewardship review. I also want to put a disclaimer here to always use your clinical judgment whenever you're assessing a patient's antibiotic therapy and to engage with your multidisciplinary healthcare team. This is just a general thought process that I think works for most of the patients that I see. However, it will not apply to every patient case that you encounter. Therefore, this thought process is intended to be used for pharmacists practicing in a collaborative setting and not intended to be used alone without consulting other medical team members when making medical recommendations. Without further ado, let's get started. Everyone's thought process will be different. This one works well for me because it allows me to track the patient's progress from when they were first started on antibiotic to their current status now. And therefore, this allows me to determine how they are responding to their current therapy. But feel free to tweak this to whatever way will work best for you in your clinical setting. The first thing I do before I dive into the patient's chart is I do a quick screen to see what antibiotics they're on, for what indication, and how long they are into their therapy. This should be quick, and it usually will take me 5 minutes max. The purpose of the screen is so that I can get a better sense of their diagnosis or working diagnosis if the workup is still in progress, so that I can target my review. The doctor's notes will be helpful here because we need to rely on their diagnostic abilities to help us figure out the indication for antimicrobial therapy. I will also take a note of their current antibiotic that they're getting now, how many days of therapies they have already received with this current antibiotic or any preceding antibiotic right before this. I will look at any positive or microbiological cultures that have been collected, such as blood, urine, any fluid cultures that are relevant to the diagnosis, and as well as any imaging tests that have been done. To get a sense of how sick the patient is or how they're responding to therapy, I will also take a look at their vital signs, such as their temperature, blood pressure, heart rate, their oxygen status, for example, if this is a pneumonia that we're treating. I find that by not doing this quick screen, I end up spending a lot of time on reading through irrelevant information through their chart. Now that you have an overall picture of what's going on, It's time to do a more targeted search into the patient's chart to gather evidence to support this diagnosis for antibiotic use. Your initial screen should help you identify the relevant imaging, relevant cultures, as well as the relevant clinical signs and symptoms to look for to support this diagnosis or indication. I find that with the targeted review, it's best when done actively, rather than passively reading through the patient's chart and just gathering information. For example, if a patient was admitted primarily for shortness of breath and requiring supplemental oxygen when at baseline they are on room air, then I want to know if a chest x-ray has been done to rule out causes like pneumonia, heart failure, or other reasons for their dyspnea. Then I would go into their chart and look specifically for any chest x-ray that has been done and look at the results. Being active with your targeted search may be a bit challenging for new pharmacists because it requires you to wear a diagnostic hat. However, this is a skill that you can be better at. And you can improve on this skill by reading up on the epidemiology, clinical manifestation, diagnosis of these common infections that you see and applying it to more patients. For the first part of this targeted review, I would take you back to what you learned in pharmacy school, the NESA acronym. So N starts for necessary, or we're assessing the indication. When assessing the indication, I'm looking for evidence to support this diagnosis. In this part, I'll be digging into their charts to see if their signs and symptoms, their diagnostic tests, their lab tests, or cultures support the diagnosis that we're using the antibiotic therapy for. Similarly, I'll also brainstorm or research into other non-infectious causes that could explain these symptoms and see what kind of tests or workup is being done to rule these out. As pharmacists, we can help the team by screening through the patient's medications to see if there may be drug-related causes that could be explaining their primary symptoms. A clue here to rule in or rule out other non-infectious causes for explaining the patient's symptoms could be looking at how they're responding or how their symptoms or signs are improving with antibiotic therapy. For example, if the patient is day 5 into their antimicrobial therapy and the patient has not improved much in terms of their clinical signs and symptoms, and there are other tests that support a non-infectious indication that have resulted, then this may not be an infection and may not be something that will require antibiotic therapy to be continued. Once we finish with reviewing the indication section and we deem that infection is the most likely cause for the patient's symptoms and that antibiotics should be continued, then we move on to the E of the NESA portion of the acronym, which is assessing the efficacy of the antibiotic that is chosen for the patient. When I look at the drug, I want to see if this drug will reach the site of infection in therapeutic concentrations. A notable example is for a drug like daptomycin, because it is inactivated by pulmonary alveoli surfactants, it will not be effective when used to treat pneumonia. The other notable example that I can think of is when treating CNS infections, we want medications that will be able to penetrate the CNS. An example of a drug that won't penetrate this would be ertapenem. If we're still treating empirically, meaning we're waiting for culture results to come back, or if a culture has not been ordered, I would also want to see what are the common pathogens implicated in the infection that we're treating, and is the current drug choice something that will cover these common bugs that we might be expecting to grow. And we know that with bugs, they can develop resistance. So it will be also helpful to look at your hospital's or area's antibiogram to determine the resistance patterns of these pathogens around your area and tailor your antimicrobial therapy based on this data. If we have culture results for the site of infection that we're treating, then we could take a look at the species and sensitivities of that organism that we're growing and tailor our antibiotic further to target the specific organism. And we call this directed therapy. As I'll mention later on in the series, this would be a prime opportunity for antimicrobial stewardship. If we have a bug, such as an E. coli growing from the urine culture that's sensitive to narrower agents, such as ampicillin or first-generation cephalosporins, and the patient is currently on something like ceftriaxone, which is broader, then we will want to narrow down the antimicrobial therapy to something like amoxicillin or Keflex or Ansef, for example, to try to reduce the side effects and development of resistance to these broader agents. Another thing to consider here is to see whether synergistic therapy is needed. For some indications like Enterococcus faecalis endocarditis, we may use a combination of ceftriaxone and ampicillin for better outcomes. To be able to know this, you'll have to be familiar with the guidelines. So always look up the most recent guideline recommendations for whatever indication or infections that you're treating. I'll also take a look at the antimicrobial dosing that they're currently receiving to make sure that it is not underdosed for their renal, liver, function, or weight, as well as the site of infection and potentially the specific pathogen that they're growing. For example, for treating bacterial meningitis, we do recommend higher doses of antibiotics to be used so that they're able to penetrate the blood-brain barrier and get into the CNS at therapeutic concentrations. In terms of assessing the patients here, I want to see how they're responding to antibiotic therapy. If they were initially febrile on emission, have they achieved defervescence? And if they were initially requiring 6 liters of nasal prong in terms of their oxygen requirement, are they now requiring less with the antibiotic therapy on board? Have their white counts normalized when it was initially high? And are they now normotensive when they initially presented with hypotension? I'll also screen for any drug interactions that might reduce the efficacy of the antibiotic used for treating the infection. The most common one that I encounter is ciprofloxacin oral given concurrently with other antacids, calcium supplements, iron supplement, for example. After assessing for efficacy, I'll progress to the S part of NESA, which is safety. I'll assess whether the patient is experiencing side effects with the antibiotics that they're receiving. As pharmacists, we play an integral part to help the team assess for this. Therefore, know all the monitoring parameters that are common or rare and serious of the antimicrobial therapy that your patients are receiving. Therefore, if the side effect occurs in your patients and you have been actively monitoring for it, you can then bring it up in a timely manner to your team so that effective interventions could be given before anything more serious happens. For example, we had a patient on linezolid therapy where thrombocytopenia induced by the therapy was caught quickly by a pharmacist and allowed the medication to be stopped for platelets to recover without any need for platelet transfusions. Another one to watch out for with any antibiotic treatment is C. difficile diarrhea, which can occur up to 3 months after antibiotics are discontinued. Next, I'll take a look at their dose in relation to their kidney or liver function as well as their weight. Are they currently receiving a higher than necessary dose? On a similar note, are they at risk of experiencing side effects with concurrent drug interaction? And lastly, we'll take a look at the A in NESA, which is adherence. For this part, I'll take a look at their MAR and ask a nurse if necessary. Are the patients spitting their medications out? Are they being combative and refusing their medications? Are they vomiting up their pills so that they're not being absorbed? And do they have any GI tract abnormalities that would prevent adequate absorption of their medications? Going through this assessment should give you an overall impression as to whether antibiotic is needed based on whether there is an infection or not, and to give you an idea of how the patient is responding to their antibiotic therapy. Based on any issues that you have identified through your assessment process, this should help you formulate your plan, which could consist of suggesting to stop or continue antibiotics, whether at the current dose or whether doses should be adjusted based on the patient's renal, liver function, or their weight, whether any drug interactions need to be managed to ensure optimal absorption or to reduce side effects, and or whether the routes of administration need to be changed to ensure adherence. Lastly, and most importantly, this is where we can incorporate simple antimicrobial stewardship principles or strategies to see if we can optimize their antimicrobial therapy further. I'll go through each of these stewardship principles in more detail in my later videos of this mini-series. But just to give you guys an idea of what there is to come, these include duration optimization, dose optimization, de-escalation strategies, and IV to PO step down. Now that you have a plan in place for their antibiotic therapy, you can then approach your team members to discuss your assessments and findings and to pitch your suggestions. So that's it in terms of the thought process. I encourage you to take the daring move to start using this approach in your practice. With your first few patients, it will seem very unnatural, and that is completely normal. But with more patients that you see using this approach, it will slowly become more natural. I'm interested to hear how this approach has worked for you, so feel free to leave me a comment below if you have any feedback or if you want to share your experience using this thought process. I look forward to seeing you in my next video in this ASP mini-series. Bye for now.